Good afternoon, everyone. I'll be presenting my paper on visually significant OCT characteristics of epiretinal membrane in uveitis and its correlation with uveitis profile. Epiretinal membrane develops frequently in patients with uveitis, and SD-OCT visualization and improved ultrastructural evaluation of not just the pathologies of ERM, but also the underlying retinal changes. However, in previous studies, these observations have not extended to the uveitic ERMs. So the study analyzes the correlation of various characteristics of ERM secondary to uveitis with visual acuity, progression pattern, and role of steroids and immunomodulators in the progression of ERM. It's a prospective observational study which we included patients over 18 years of age showing an SD-OCT supported diagnosis of ERM who had either active uveitis on treatment or history of previous uveitis. We excluded patients with coexisting retinal condition, traumatic uveitis, previous eventful intraocular surgery, documented ERM before the onset of uveitis, significant media opacity, and patients who underwent cataract surgery within this 12 months period. Clinical data was collected at baseline and at 12 months follow-up. All cases underwent a spectral domain OCT in a 6 into 6 millimeter area was scanned with raster pattern, and all measurements were quantified with built-in calipers. The ERM location was classified as foveal, parafoveal, and macular as depicted here. The central ERM thickness, the maximum ERM thickness, and the location of the point of maximum thickness all recorded in microns at baseline and at 12 months follow-up. The attachment pattern of the ERM to the inner retinal layer was classified as focal, global, and mixed as seen in these images and as previously described by Nazari et al. In his paper. The central subfield thickness and the logMAR best corrected visual acuity were recorded at baseline and 12 months where inflammation was under control and there was no complications like cataract or cystoid macular edema. Treatment modalities included topical and systemic corticosteroids. Immunomodulators were added wherever necessary, and we aimed at zero intraocular inflammation. Statistical analysis using non-parametric tests using SPSS software 20.0. Coming to our results, we analyzed 34 eyes of 25 patients with a mean age of 41.4 years. 44% were males. Anatomically, anterior uveitis was the most common, and etiologically, idiopathic uveitis was most common. 36% patients had bilateral ERM. The mean duration of uveitis before the OCT diagnosis of ERM was 12 months. It was 8 months for posterior uveitis. Coming to spectral domain OCT characteristic, 65% of the ERMs were foveal to begin with, which progressed to 88%. That is, 8 eyes progressed from a parafoveal to a foveal involvement in 1 year. 8 eyes also developed cystoid macular edema. Foveal contour was lost in 15 eyes, and 10 eyes developed ISOS disruption. The median ERM thickness at fovea and the median maximum ERM thickness showed significant increase in 1 year, and the median distance of the point of maximum thickness from the fovea also showed a significant decrease. The median central subfield thickness increased significantly, and cystoid macular edema was more associated with presence of focal attachment of ERM. Foveal involvement with ERM, loss of foveal contour, and ISOS disruption were associated significantly with reduced visual acuity. There was no significant difference in the ERM thickness in the three treatment arms, that is without oral steroids, with oral steroids, and oral steroids with immunomodulators. Mean logMAR visual acuity worsened significantly in 1 year. In our study, all patients were N8 or better at baseline, but in 1 year follow-up, 47% had dropped below N8. The rate of metamorphopsia increased from 20% to 80%, and there was a significant correlation between the movement of the ERM towards the fovea and the visual acuity. Coming to our discussion, ERM was observed to appear earlier in posterior and intermediate uveitis as expected because of the closer proximity of the inflammation to the retinal surface. And in previous studies, we have seen that non-idiopathic ERMs were mostly focal in nature. In our study, 32% were focal in nature, but the global ERMs also showed a more tendency to progress into the focal types, probably due to the histological elements that had a contractile property. In uveitis, intraocular inflammation may also contribute to the photoreceptor layer disruption apart from the physical effects of the ERM. And it is expected that ERM that involve the fovea have a greater visual impairment because of the greater sensitivity to smaller structural alteration. Our study also showed there was a greater tendency of foveal involvement of the ERM over time. That is, uveitic ERMs may begin in a peripheral macular area but spread towards the fovea. Cystoid macular edema could be as a result of inflammation as well as the tangential forces of the adherent ERM. However, in our study, we removed the inflammation factor by recording the OCT parameters when the eye was relatively quiet. And we had seen that the cystoid macular edema was more commonly associated with focal attachment of ERM. In our study, we saw that earlier detection of ERM did not halt the progression of ERM or prevent a foveal involvement despite aggressive inflammation control. That is, there was no significant difference in the 3 treatment arms. Therefore, we say that it is unnecessary to use drugs which are not warranted once the inflammation is under control. And surgical removal of ERM may be indicated in focally attached ERM because they cause higher rate of cystoid macular edema and vision loss. The limitation of our study includes a small sample size and non-randomized design, and in eyes with broad attachment, it was difficult to take the isolated ERM thickness. In conclusion, uveitic ERMs which are focal attachment have a higher incidence of cystoid macular edema, therefore a worse visual acuity. Progression pattern involve of more foveal migration. Once the ERM is established, progression will occur despite inflammation control. And ellipsoid layer defects progress despite inflammation control due to mechanical forces of the ERM. This study serves as a guide in tailoring proper follow-up and management. Thank you.
How long was your study design?
12 months. 1 year follow-up of the patients. Okay. We included patients over 2 years. We followed up each patient for 1 year.
Okay. In spite of the inflammation stopped, you continued with the OCT images, is it?
We continued to take the OCT. We kept the inflammation under control with either topical
Correct.
Steroids or oral steroids or immunomodulators to keep the different groups. There was no progressed in a similar manner.